So, in continuing the theme here, sleep-wake disorders, we're going to go over insomnia disorder, hypersomnolence disorder, narcolepsy, obstructive sleep apnea, circadian rhythm sleep-wake disorder, nightmare disorder, and of course, restless leg syndrome. So that's the overview here, the sleep-wake disorders that I'm going to cover. Let's dive right into the insomnia disorder, DSM-5 criteria. So, as you know, DSM-5 criteria is long-winded, so here we go. Criterion A prominent complaint of dissatisfaction with sleep quantity or quality associated with one or more of the following. Number 1, difficulty initiating sleep. Number 2, difficulty maintaining sleep. Number 3, early morning awakenings with inability to return to sleep. Criterion B says sleep disturbance causes clinically significant distress or impairment in function. Of course it does, or else it wouldn't be a disorder. Sleep difficulty occurs at least 3 nights per week. Sleep disturbance is present for at least 3 months. The difficulty occurs despite adequate time to sleep. The disturbance is not better explained by another sleep disorder. And the disturbance is not due to the effects of a substance. And coexisting medical mental conditions does not better explain the disturbance. So the bottom line with this, what do you want to remember for insomnia disorder DSM-5 criteria? Remember that it's a dissatisfaction with sleep quality or quantity with one or more of the following. Obviously, difficulty initiating sleep, difficulty remaining asleep, or frequent awakenings. You want to kind of just remember it's a problem with quantity and quality of sleep, difficulty initiating, difficulty maintaining, and early morning awakenings or inability to return to sleep. Obviously, anything that's a disorder is going to cause a disturbance that is clinically significant, or else it wouldn't be a disorder, you wouldn't be seeing a doctor. The other important details to remember about any DSM-5 criteria and the testable point is usually the time frame. So sleep difficulty occurs at least 3 nights per week, and sleep disturbance is present for at least 3 months. So you got to remember that sleep difficulty has to occur at least 3 nights per week, and the disturbance must be present for at least 3 months. So 3 nights per week, 3 months. That's the key points for the DSM-5 criteria and testable points. Insomnia disorder continued. So, it is a subjective complaint of deficient, inadequate, or unrefreshing sleep. So again, difficulty initiating, difficulty maintaining sleep, frequent nighttime or early morning awakenings. These are kind of the things that you're going to see or the complaints that you're going to hear from your patients. With insomnia patients, they often complain of decreased daytime functioning, so they feel like they can't function properly, they feel overly tired, they feel anxious or excessive arousal at night before bed. So they also, again, look for people with comorbid anxiety disorders because they're going to be people that feel anxious. Again, the anxiety disorder might better explain this, so it wouldn't necessarily, but just that look for people who have tendencies towards anxious thoughts or behaviors and excessive arousal at nighttime. A general consensus is developed from population-based studies that approximately 30% of a variety of adult samples drawn from different countries report one or more of the symptoms of insomnia. So a lot of people are dealing with difficulty sleeping. It's, again, I've said it multiple times in my lectures, that it's a thing that we're all kind of dealing with, and psychiatrists, one of our big things is, hey, we get people to sleep. That's one of our goals. Insomnia is perhaps the most difficult of the sleep disorders to treat as well, obviously because there's a lot of factors that go into the process, and sleep again is pretty challenging. So, what are the treatments? Here's some basic stuff you can always do and recommend to any patient, regardless of the situation. So you want to start with non-pharmacological techniques such as cognitive behavioral therapy combined with education about good sleep hygiene. So before you start prescribing Ambien and all kinds of other stuff to your patients to help them sleep, try some of these non-pharmacological approaches. The CBT has been incredibly successful, and also, again, education about sleep hygiene. So let's go over the basics of sleep hygiene. One of the things you want to do with sleep hygiene is you want to limit in-bed time to the amount that was present before the sleep disturbance. So you want to limit that time in the bed to the amount that was present before the sleep disturbance. You want to tell your patient to lie down only when sleepy and sleep only as much as necessary to feel refreshed. You want to use the bed for sleep and only. We also say for sleep and sex usually because that's what people use it for. So at least that's another reasonable use of the bed. Maintain a comfortable sleeping condition. So that usually is a cool, dark room. The way I think of comfortable sleeping conditions generally are cool, dark rooms. So that might be buying blackout curtains if your windows tend to allow too much light in. That may be adding an air conditioning unit to your bedroom if you don't have one. Again, keep it cool and dark. Wake up at regular times each day. So again, maintain your schedule. Avoid daytime naps if possible, and if you do any kind of daytime naps, make them very, very short. I'd say like no more than 15 minutes. Exercise regularly. Everybody should exercise, obviously. That's definitely worth your time. So putting in, I would say, a minimum of 30 minutes a day of cardiovascular exercise, such as walking, jogging, treadmill, incline walking on the treadmill, elliptical exercise, whatever your taste is, but that would be the minimum amount I would recommend on a daily basis. Limit the use of sedatives. Avoid alcohol, tobacco, caffeine near bedtime. Obviously, tobacco products have nicotine in them. Nicotine's a stimulant, and that will keep you awake. You want to avoid caffeine. Obviously, caffeine is one of the major stimulants and probably the most common drug that we all use in the United States. So, and also alcohol. Some people get into this idea of a nightcap, drinking an alcoholic beverage before sleep, but actually, because alcohol works similar to the benzodiazepine, it's not always the best choice. And long term, you shouldn't be relying on alcohol to help you sleep, so it's not a good plan. Eat at regular times, and obviously avoid the large meals before bedtime. Eat a light snack if you're hungry near bedtime, but again, avoid large meals. And practice some kind of relaxation techniques at night, such as progressive muscle relaxation, meditation, or taking a hot bath 20-minute, or taking a very hot 20-minute body temperature raising bath near bedtime. So that's another option. So these are some of the basics that you want to educate your patient about before jumping to pharmacotherapy. So insomnia disorder treatment, CBT. This is a good one. I actually like this a lot. If you have a patient with insomnia, CBT might be their best option. Evidence from meta-analysis, so that's really, well-documented meta-analyses suggesting that CBT is most helpful for sleep onset latency and sleep quality. So it helps with sleep onset latency and quality. A therapeutic response that is sustained over time is achieved in 70 to 80% of patients who undergo CBT. So that's pretty good results. I mean, if you're getting a therapeutic response that is able to be sustained over time in 70 to 80% of the people you're treating, you're doing pretty damn good in any medical field and for any disease, or for any disorder, rather. CBT also has been shown to be helpful for insomnia that is comorbid with other medical and psychiatric conditions. So again, CBT, it has multiple uses. It can be used in different contexts, and it has benefits not only for sleep, but also for comorbid depression, anxiety, etc. If CBT is not effective, brief intermittent use of pharmacotherapy may be appropriate. So finally getting into the drugs. Insomnia disorder treatment, pharmacotherapy. So let's talk about the pharmacotherapy a little bit. There are several FDA-approved medications for insomnia that are available, and they include, of course, benzodiazepine receptor agonists and melatonin receptor agonist. Advantages to using medications include, rapid relief of symptoms. So if the patient comes to you and says, hey, I can't sleep, this is ruining my life, I'm not able to go to work anymore, I'm not able to function, I'm always overly tired, well, then that could be more of an issue where you need to bridge them with pharmacotherapy as they enter CBT, as they learn good sleep hygiene techniques. But the problem with the medication is that the effects may not be sustained over time after discontinuation as they would be with CBT. So again, CBT kind of has that, not only is it very effective and works in approximately 70 to 80% of the patients, it also has some long-term staying power, meaning it lasts even after the patient stops doing CBT or stops, is not seeing, say, a counselor or a therapist on a regular basis. In general, the sedative hypnotic drugs should be used in the lowest possible doses. So this is always the technique in psychiatry or any medical field, I feel like, is start low and go slow, right? Do not go too fast. Do not up-titrate too quickly. Lowest possible doses should be used, and you need to monitor them closely for side effects. So that's why anytime you put somebody on a medication, you need to always be following up with them, because it's your responsibility then that patient is under your care. And that's especially true for elderly population. The choice of drug should be based on clinical factors and characteristics of the drug. So for example, Agents with shorter time to peak blood concentration, they aid in sleep onset, whereas longer half-life medications are better for sleep maintenance, although with the potential for daytime sedation. So you don't want to sedate the patient too much during the day, so the longer acting, longer half-life drugs might be a little too much for certain patient populations, and of course the shorter acting ones help people get to sleep if their main problem is initiating sleep. There is little evidence to guide the decision on how long these medications should be used for, but in my opinion, I'll give simply this is my opinion, so not necessarily verified by all of the research, but I would say that you should always use these medications in the shortest time frame necessary. So lowest doses, shortest time period. Get the patient on a good sleep schedule, get them into CBT, whatever the case is, but try to avoid using these medications long term. When discontinuing any of these medications, they should be tapered because you want to prevent rebound insomnia and potential withdrawal effects. So, especially if you're using any kind of benzodiazepine drugs, that's definitely something you want to think about. One that's not mentioned here that is a reasonable choice as well is melatonin. Melatonin can be had over the counter, and it can be usually about 5 milligram capsules is the standard. And although some people find great success with melatonin alone, I know it's used quite frequently in our child-adolescent population for sleep problems. And it can also be used for shift work disorder and jet lag. So people who are having trouble with jet lag when they come home, say from a business trip, they may want to try melatonin first before moving to the more serious drugs. More pharmacotherapy. So the American Academy of Sleep Medicine, so the guys and girls that study sleep on a regular basis, suggests starting with any of the short or immediate acting benzodiazepine receptor agonists or Melatonin, which is the melatonin agonist. The initial agent is chosen based on symptom patterns, so past response, cost, and patient preference. If the trial fails, an alternative drug from the same category should be attempted. So if you fail a trial with one drug, you should try another drug from the same category before moving to a different category of drug. If there's still no response to a low dose of a sedating antidepressant, trazodone, mirtazapine, doxepine, amitriptyline, used at low dose can be tried, especially in patients with a history of depression or substance use disorder. These are not FDA approved for insomnia, and their efficacy is not well established. So again, these are kind of off-label uses. Anytime you use trazodone, mirtazapine, which are commonly used in psychiatry for sleep, remember it's an off-label use unless the patient is depressed. Now, if the patient's depressed, you can argue that you're augmenting the depressive symptoms with trazodone or mirtazapine or doxepine or amitriptyline. Doxepine and amitriptyline being tricyclics, and the trazodone and mirtazapine, the newer generation tetracyclic antidepressants. So they're not FDA approved, they'll remember that. While drugs like quetiapine and olanzapine have insufficient data to support their use for treatment in insomnia, they can be helpful in patients with sleep disorders and other psychiatric illnesses. So what you'll see is a lot of times you'll see Seroquel a lot used for sleep, 50 milligrams say, but really you should have a good indication for using that medication, like you're treating the patient's bipolar disorder, you're treating the patient's psychosis, etc. You should not just use these medications just for sleep. Likewise, melatonin, other herbal supplements such as valerian root have not been shown to improve symptoms of insomnia. So for insomnia, melatonin maybe not so good, but I mentioned a couple of cases where melatonin is used regularly, again in child-adolescent population for sleep disturbances, and in cases of shift work disorder and jet lag, it can be used. And it's worth a shot. Now this chart I don't think we're going to be able to see very well, but what I have here is really just the melatonin receptor agonists, which are Ramelton, the antidepressant medications, amitriptyline, doxepine, trazodone, mirtazapine, the anticonvulsant medications that are used. And this is just kind of like a general chart. You can probably Google this and find the commonly used medications for treatment of insomnia. Obviously, the main ones are like zolpidem, so Ambien, and all of those other benzodiazepine receptor agonists. They're the non-benzodiazepine receptor agonists, which is a weird term. It's kind of contradictory, but that's what they basically are. And they're listed at the top. At the bottom, we have some of the other ones. So those medications, again, look that chart up. It's more so just sort of knowledge you'll want. The newest FDA-approved treatment for insomnia is Belsomar, and Belsomar was approved by the FDA in August of 2014. It's the first orexin receptor antagonist for insomnia. So remember, orexin, also known as hypocretin, is important in narcolepsy. So the orexin neuropeptide signal system is a central promoter of wakefulness. So if you block the binding of wakeful promoting neuropeptides, orexin A and orexin B, to those receptors, theoretically it should suppress the wake drive. Approval was based on 3 clinical trials involving more than 500 participants. The recommended dose right now is 10 milligrams for most patients. After taking 20 milligrams, impairment of next day driving was observed. So 10 milligrams is kind of your basic dose at this point. So that covers all the details on insomnia. It was a very, very long-winded discussion, but it's a lot of information, but it's all valuable.